Oh, thank you, Giuseppe, thank you, Judge. I'm not sure that this is something good, be member of the task force of the last guideline, because the last guideline about hypertension raises some very high criticisms. But I'm trying to share with you the news coming from the guideline presented in London at the meeting of ESC 2024. So the first question that the task force made themselves was, do we really need a new guideline for hypertension? Well, the answer was very easy. Yes, of course, because the prevalence is increasing, the number of patients treated are suboptimal, and we don't have a real control of the blood pressure, especially in women, for example, and still hypertension is a major risk of factor for morbidity and death. And these are some figures. 50% of the world population does not be hypertensive, 35%, only 35% are treated, and when you treat the patient, you reach the goal only in less than 10%. So I told you there are there are so many news in this guideline, 57 new recommendation about definition and classification, about diagnosis, about the measurement, about preventing the pharmacological treatment as well. But another very important thing is the big chapter related to the patient-centered care. Is impossible to show you everything. I'm focused on probably what is the most important change. We try to simplify the classification of hypertension, and I think you have heard that we introduce a new level, so-called elevated blood pressure in this guideline. That it means that when you have a patient with systolic blood pressure around 120 and 139 for systolic blood pressure, I told you, and 89 for diastolic blood pressure. This is a big change, and this is a very strong change. And why we decide to do that? Just to introduce the topic, look at the right side of the slide and look at when you have the blood pressure above 110, 115, look at the increase of the burden of cardiovascular and premature death. So these are the previous guideline classification based on hypertension grade. We decided to simplify and put only 3 different situations: a non-elevated blood pressure and less than 120 and 70 millimeter of mercury, elevated, I told you already the range, and hypertension above 140 and 90%. You can ask me why you define non-elevated blood pressure, what we believe that is a normal blood pressure. Well, because if you look at this data that we look at very carefully, you can see starting from 115 millimeter of mercury and for the systolic, and more than 75 millimeter of mercury, the level of blood pressure, you increase the mortality in our patient. And if you look at these two very nice paper, you can see that the curve change, the steeper of the curve change around 100 millimeter of mercury. So the most criticized elevated blood pressure within 120, 139 systolic blood pressure. So you can tell me how is possible that we have to treat patients that have this kind of blood pressure or stay in this range of blood pressure? This because we know that there are several trials that came after the 2018, where the last guidelines were released, like a Sprint, like a SPRI, like the rural Chinese hypertension trial, that tell us that the blood pressure goes directly with the risk of event or even the death. This is a huge number of people, and this is impossible to treat all these people. So the idea is that you have to correlate the situation of your patient. I'm talking about patients with 120, 139 millimeter of mercury for systolic blood pressure. So people that we believe, or we had believed that are in a normal range, in a safe, let's say, range. And if you look at this data, you can see that there is for sure relative reduction of cardiovascular event when you lower the blood pressure, and the risk, the patients that are at high risk benefit better, or benefit better of the lowering treatment. And if you look at this slide, where you can see the cardiovascular risk stratified by blood pressure, you can see that even when you look at the blood pressure under 10, you can see the blue bar. That means that you have a cardiovascular risk that is higher than what we thought. And if we talk about this kind of patient, so patient with elevated blood pressure, 30% of disability, adjusted life years lost related to cardiovascular occur in this patient with 115 and 140 millimeter of mercury of blood pressure. Indeed, several trials in the last few years tried to put together the level of blood pressure with the risk stratification. These are Sprint or the SPRIT or the Chinese trial, and this is why we decide to put in a very clear flow chart what you have to do when you are in this situation. Patient with elevated blood pressure, 120, 139, and follow few things. First step, you have to identify your very high risk patient. It's very easy for the cardiologist, because if you are diabetic, if you have organ disease, if you have familiar cardiovascular disease and so on, it's very easy. And what you have to do? The idea is to try to advise the patient and change lifestyle, and check your patient, recheck your patient within 3 months. And if after 3 months of this advice, the patient shows the same level of blood pressure, you have to treat the patient, because you save cardiovascular events in this patient. There are, I'm going very fast because I know that the time is important. So class 1B recommendation for high-risk patient. If you don't have a high risk, you can use SCORE. Which SCORE? SCORE 2, because the SCORE 2 is able to change, to define better the cardiovascular risk. SCORE 2 for older people, SCORE 2 for diabetics people, And this is something that can help you to decide if you have to treat or not the patient. 2 slides. There are also, you have to consider also shared risk modifier, like sex-specific modifiers, like, for example, it's typical for women, and everything that is related with pregnancy, for example, or shared modifiers risk, like ethnicity or family history or socioeconomic situation, and you have the complete list. But the last slide, what we want to change is to move from an hypertensivologist view of hypertension treatment to a cardiologist view. In other words, you have to treat your patient when the risk is higher, and when you decide that even if the blood pressure is a range that we believed that was normal, the risk is very, very high. Thank you very much.